안녕하십니까?
Hello, I'm Dr. Sun Young Hui from eGood Dental Clinic. Here's the case we'll be discussing in today's online surgery. This patient was referred to me by another practitioner. Looking at the case, it appears the patient previously had implants in the mandibular right side, which then developed severe peri-implantitis. This is the initial X-ray. Based on the X-ray, we can infer that implants were placed at sites number 44 and 47, but eventually had to be removed. Considering the soft tissue is fairly well healed, it seems that some time has passed since implant removal. There are several issues visible on this X-ray. In the maxillary left side, a natural tooth and an implant are splinted together. Also, at site number 37, we can clearly see an advanced case of peri-implantitis. As you can see, the abutment cuff height is only 1 millimeter. In my experience, using a 1 millimeter cuff leads to this kind of outcome over time. For this reason, I generally do not recommend using 1 millimeter or 2 millimeters cuff heights. Now, back to the main point. The patient presented with this issue in the mandibular right side. At this stage, implant placement is simply not possible. So, we need to create the necessary conditions for it to become feasible. First, let's look at the CT scan. This is site number 44, and here is number 45. The canal is visible, and the mental foramen is located just posterior to number 45. Due to sclerosing osteitis, the bone is almost entirely cortical. As those experienced with this know, vascularity is poor in this type of bone, making regeneration extremely difficult. The situation is quite concerning. When reflecting the flap for vertical augmentation, we need to be extremely careful with the mental nerve, as the mental foramen is located right here. If a rigid material like titanium mesh comes into contact with this area, it could cause unintended lip numbness. So we need to be very cautious. Now, let's move to the posterior. Here, we can clearly confirm that the implant was removed. Posterior to this area, no implant has ever been placed. You can see a sharp alveolar crest, a typical finding of atrophy after extraction. For this patient, vertical augmentation is required as the first step. One commonly used approach nowadays is the sausage technique using a collagen membrane, which many of you may have seen on YouTube, and which I also use frequently in my practice. But in this case, I felt it would not be ideal, because the vertical bone deficiency in the mandibular right first and second premolar region is simply too severe. Because the deficiency is too severe, vertical augmentation would require tenting screws. Without them, it would be nearly impossible to maintain either vertical or buccolingual volume. For this reason, I decided against the sausage technique. The second option was to use a titanium mesh. When using a titanium mesh, it can be either 3D printed or manually cut. I've found that using it as a single unit can be problematic. If soft tissue perforation or dehiscence occurs at even one site, the whole thing must be removed, which becomes a major complication. So I thought, honestly, this is a bit risky. Even for me, I felt a bit hesitant about using that technique. That's why I thought it would be better to use separated titanium meshes. If one side has an issue, only that part needs to be removed. With that in mind, I decided not to place implants first. Instead, I planned vertical augmentation using Ostem's OB3 jaw builder, supported by anchor screws to keep it in place.
일단 vertical augmentation을 하는 걸로 계획을 세웠습니다.
Looking back at the preoperative panoramic radiograph, ideally, we would want to augment the bone up to the distal crest of tooth number 43. But realistically, achieving primary closure at that level would be extremely difficult, no matter what technique we use. In cases with such extensive bone defects, especially in the mandibular posterior region, a buccal flap alone does not provide enough advancement. So, we first gain advancement with a periosteel releasing incision on the buccal flap, and then gain additional flap length by blunt dissection of the lingual flap. Even with these techniques, I wondered whether primary closure could be achieved at that height. That's why I planned the augmentation at a slightly lower level. This is the pre-operative view. As you can see, I felt that reaching this height would be quite challenging. So, my goal was to build up only to this lower level, and I used the os builder for this purpose. Now, let's watch the video to see how I perform the surgery.
기운도 아프세요? 네, 알겠습니다.
물 묻혀줘? 네.
네, 어떻게 잘 보셨는지
I hope that was helpful.
뭐 흔하게 하는 수술은 아니고
This is not a routine surgery, and I still feel a bit nervous every time I perform it.
가지고 맨날 쫄려가지고 수술을 합니다.
That was the preoperative state. Now the flap is reflected. Every clinician has a slightly different approach. Some prefer to perform the periosteal releasing incision immediately after reflecting the flap, but I personally prefer to do it a bit later. I avoid doing the releasing incision too early because it can cause continuous bleeding.
조금 블리딩 양이 많을 걸로 걱정이 돼서 이제 그렇게 하고 있습니다.
As you can see, the sites where the implants were removed are filled with granulation tissue. I've debrided the area using a curette. Then I placed 2 anchor screws first. Placing anchor screws is straightforward. You can place them manually, with a hand driver or using an engine. In this case, I placed them manually. Then I placed 2 OB3s. I considered adding one more, but I felt it wasn't necessary for this area. As you can see, I recommend performing cortical bone perforations as thoroughly as possible before grafting. I used 2 OB3s and secured them with cover caps. As you know, using xenografts or alloplastic grafts alone for this type of vertical augmentation often leads to poor results. So, I harvested autogenous bone from the ramus using an auto bone collector and mixed it with xenograft to achieve more favorable outcomes. I placed a collagen membrane over the titanium mesh to prevent direct contact between the soft tissue and the titanium, which helps reduce the risk of dehiscence later on. For this reason, I always make sure to cover the mesh with a collagen membrane first. As you may have noticed in the video, additional lingual flap advancement can be achieved by gently detaching the tissue using a thick periosteel elevator, a Selden elevator, or even the pinky finger. In reality, beginners often struggle at first because the procedure can be quite intimidating. Patients also tend to feel some discomfort with this type of surgery. Patients may experience some discomfort, but it is usually manageable. Now the suturing is complete, and this is the post-operative panoramic view. I still wish we could have gained a bit more vertical height, but due to the technical difficulty of adjusting the anchor screw height, this was the final level we could achieve. In a way, I think the difficulty of making real-time height adjustments can be a limitation of the OB3 jaw builder. Still, once this level of height is achieved, I feel that implant placement becomes manageable. CT shows the augmentation is complete. This area was my main concern. I tried to avoid it, but as you can see, a tiny amount of graft material has slightly displaced here. The patient had some temporary paresthesia postoperatively, but it resolved within 2 weeks. Since then, the condition has remained stable without any major complications. In the posterior region, excessive augmentation can be demanding for both the surgeon and the patient. So, I performed this procedure with the goal of achieving just enough height for successful implant placement. The surgery is complete, and now we wait. Most importantly, any exposure could lead to failure. That would mean starting over or requiring prolonged dressing. In short, it leads to a very challenging situation. This is the intraoral view at 1 month postoperatively. The site has been well maintained without dehiscence. Whether using a customized titanium mesh or a manually bent one, I believe the first 8 weeks are critical. If exposure occurs within 8 weeks, especially when the main pores are involved, removal of the mesh is the appropriate choice. But, if exposure occurs after 8 weeks due to reduced blood perfusion or thinning of the soft tissue, you can consider several options, such as dressing, grinding down the mesh, or removing it earlier than planned. This means that several options can be considered. But if exposure occurs within 8 weeks, it essentially means starting over, just like having to retake an exam. So if you keep in mind that 8 weeks is the critical period for titanium mesh, your clinical decisions will become much easier.
편하실 걸로 보입니다.
If I get a chance, I'll share a follow-up video later on, showing the implant placement at the time of mesh removal in this patient.
보여드릴 수 있는 기회가 있으면 다시 시리즈로 한번 소개를 해드리겠습니다. 오늘은
That's all for today. Thank you for watching.
같이 함께 동영상 봐주신 여러분 감사하고요.
I'll see you next time with an even better case. Thank you.